Good afternoon, everyone. Thank you again for joining us for this post-screening discussion of Aftershock. The Clinical and Translational Science Collaborative of Cleveland is a collaborative among Case Western Reserve University and its affiliated hospital systems, the Cleveland Clinic, Metro Health, University Hospitals, and the Louis Stokes Veterans Administration Medical Center. We aspire to be a catalyst for high-quality clinical and translational research, both locally and nationally, by changing the culture and environment of biomedical research, sharing resources and expertise, and streamlining the research process to move translational research from bench to bedside into the community. And we hosted this screening today to spark conversation. That's what we like to do, to be catalysts for. And today is Maternal Health Awareness Day. That is something that ACOG started a couple of years ago to continue to raise awareness about health disparities, specifically for the crisis that we're seeing with mothers, marginalized communities, Black mothers, Hispanic, Latino. And as you've seen in the film, they are talking a lot about that and about the history and how we are here today, why we're here today. So in this discussion, let's kick things off with kind of your initial takeaways from the film, some thoughts that you had, things that might have triggered you, things that you didn't know. And please feel free to take yourself off mute, turn your camera on, or type your thoughts in the chat.
So for full disclosure, I'm the ACOG District 5 Legislative Chair, which includes Ohio, Indiana, Michigan, Kentucky, and Ontario. So I was glad to be seeing things done in the maternal health and health equity space. There's a lot of work to be done for reproductive justice in Ohio, and I think this is sort of one end of that spectrum, and there's another, there are lots of other areas to work. I was fascinated to see that they did sort of on the edge of things talk about teen birth, which is a program through Harvard, and the March of Dimes is doing some research in support of. I wish they had talked sort of more about that, because I think it's an interesting thing that we're just starting. I'm actually at Akron General as part of the Cleveland Clinic. So I love that we're bringing this to the forefront and discussing what's pretty much can be a very uncomfortable topic for people, because we don't necessarily find it comfortable to address bias, implicit bias in the places that we work. So I'm just glad to be seeing people just putting it out there.
Excellent. Thank you for joining us, Amy.
Yeah, I think as an OBGYN, I know the statistics. One of the moments that really struck me was when one of the women was talking about birth for Black women being like the equivalent of when a Black man gets stopped by the police. It really struck me as like, just what it must feel like on that side looking at these numbers. And it was just, hearing personal stories is always very different than looking at numbers, and looking at the communication failures that were underneath a lot of the problem, a lot of these deaths, and thinking about it that way. I love Neil Shah. I like everything that he does. So I was glad to see him included in this. But it's an overwhelming problem to deal with because there's so many layers of problems underneath it.
Thank you. How does this information presented through a family lens, so those personal stories, alter or change your perception of the U.S. healthcare system, especially for marginalized communities and communities of color? If at all.
Yeah.
And Amy, maybe you could provide a little bit of context from your work as it pertains to this question, or I'm just very curious now that we know that you're on the call, how your work intertwines. I hate to put you on the spotlight, but
You can absolutely put me on the spotlight.
wonderful.
as sort of as being part of ACOG, and the personal stories, I think that these really do make you think, because you think this is not how I think of, I look at it and I think where, like, I am looking like, this is what this family felt in this moment. And you can make it as looking at it from being an OBGYN of like, yeah, but what happened? What was that OBGYN? What was that doctor? What was that hospital thinking? Because that's not how I would have done it. And I don't understand. And remind myself of like, that's how the family had, like, I was the one part that really struck me was how they kept asking, is she doing drugs? Is she doing drugs? Is she doing drugs? And I'm like, what is anyone thinking? And that's all the family heard of who knows how many other questions they asked her. That's what they heard. And that perception that started right when EMS arrived, like, just tore at my heartstrings, because they felt attacked from the moment they interacted with sort of like the basic EMT people taking her to the hospital. And so they were on edge before they even left their own comfort of their own home. And like what that brings into the healthcare system once they hit the doors where I'm at, and how those layers and layers and layers can just build up. And we keep, like, how do we stop like meeting that and change the narrative so that people feel heard, and we don't ask those questions, and we make people feel like they're communicating. And I think that's where Neil Shah's work starts to sort of do some of this stuff there when we start talking about teen birth and that. And so I very much appreciate the patient stories, because I think they bring that to this as a teaching point and as like for legislative stuff, to be honest. So you're talking about advocacy and legislation. So
Absolutely. How important are films like Aftershock in bringing forth conversations around these topics to communities that might not have access to information regarding these topics? So I think, Amy, you've hit on the teen birth. And when I think about that, you don't really hear much about it. At least I feel like there was an uproar probably like when I was in school, but like, where has that conversation gone? Are those conversations still happening? And how can a film like this, what kind of impact would that have on advocacy as it pertains to teen birth and research when we think about social drivers of health and what might contribute to the teen birth rates as they stand today? And Dr. Green,
I
yes.
think that, and I'm going to ask Marjorie to speak about what she thinks too, but I think that if we're not hearing enough about it, change is slow. And it's steady, it's slow and steady, because I didn't know anything about teen birth before, and the concept. And
You're saying team, TEAM, right?
Yes, team.
Yeah.
So and that's what Neil Shah's program is like called now through March of Dimes and what we're doing. And so the idea of like centering around the patient and what she wants things to be, like the centering pregnancy model of like, and that's kind of outpatient and this is inpatient. And I think it's slow to change, which is why it's sort of there, but we're not seeing it everywhere. So it's slow.
Dr. Greenfield, were you about to say something?
No, I was going to say, the conversation about inherent racism in care and inequity and outcomes is a conversation we're having a lot in my department. And we have once a month, we have what we call quality grand rounds, and 15 minutes of that is reserved for a topic related to racism or social justice. So, there's been much more conversation in the last 5 years than I've ever heard before. I feel like there's an inherent disconnect between the way obstetrics is taught in terms of best practices, which has led us to the cesarean rate that we have now, and the way that, like, it shouldn't need this much intervention in order to have a baby. And I keep getting sort of stuck in that, I don't practice anymore. I stopped practicing in 2020. So I have no power in the day-to-day, management of patients or communication with patients on labor and delivery at university hospitals. But, there is more conversation, and we're doing a lot of group prenatal care and other things that have been shown to improve outcomes. There's certainly a lot of conversation about it, but I feel like there's intrinsic conflict in the basic way that we think about managing labor that I think is part of the problem. I don't know, Amy, I'd be interested to hear what you think of that.
We do the centering pregnancy with the residents, and there's still, traditional care. And I haven't seen that carried through to like private offices in our region or in our area in Ohio. Like, I know that there's some of the Cleveland Clinic offices are doing it, but it's mostly driven by the midwives. And some of it flat out is the idea of how we're expected to provide, how we're trained to provide obstetric care, and how we're expected to meet so many patient visits and so many things while you're on call that make things like teen birth harder. Like right now, our residents generally have the attending physician will call in and speakerphone with the patient and all of that, but you have to make a commitment to that, from the nurse being there for the patient, for the resident, and the physician, or if there was a midwife, also having the midwife there and those things. And the payment model doesn't support that. And then the background overall education isn't supported by that either. And so we have these really innovative ideas, but we haven't changed the way we pay for obstetric care to let it be feasible for hospital systems and practices, whether they're private practices, FQHCs, employed practice models, all of those things, to sort of meet the revenue stuff, whether it's with midwives and nurse practitioners or physicians and residents. And so we talk about these things, but we don't take the next step of making how does that translate into how we practice in the office, so that what patients need is met. And there's also there's a disconnect in some of that too. Does that make sense? So we have
Yes, thank you, Amy. Shannon?
Thanks so much for coming today. I work with Jaleese in the CTSC, and I had a couple of thoughts. Is anyone aware of any quality improvement projects currently going in this area? I'm not sure if in Cleveland or anywhere in the teen birth realm. And then my second question is, what do you think are some of the biggest barriers to why there aren't, enough Black midwives and doulas in the field?
So I'll take the teen birth thing. Yes, we're using teen birth at Akron General, and they are piloting it at Hillcrest, which will be an interesting compare and contrast, because at Hillcrest, 100% of the physicians and midwives are employed by the Cleveland Clinic. And at Akron General, it's a mix of employed physicians and private practice physicians. And so it'll be interesting to see how that works out, because I think the just adds an extra layer.
I only ask, I'm in the Masters of Healthcare Management program at Weatherhead, and this summer I have to think of a quality improvement project. And I was thinking, what can I dip into here that's feasible in a 12-week period that could potentially be measured, within this time frame in the city of Cleveland.
So at UH, we have a pretty good quality infrastructure in terms of data collection that would probably be helpful to you, and a lead person on OB quality who is really interested in the issue of equity, which is Nancy Kostler. The thing that Nancy and I get into conflicts about is that she's really influenced by a pure medical model for childbirth, and data that comes out of the medical model in terms of risk. And it makes you look at risk differently when you're thinking of birth as a physiologic event, as opposed to kind of a medical thing that needs to be managed. But that said, I think she could be very interested in this project and working on it with you. And she has quite a good infrastructure.
Thank you.
And I think that we walk that fine line, right? As OBGYNs we're sort of trained in the highest risks of the patients, and stepping back and not only managing all of the medical complications that predate the pregnancy, whether they have diabetes or hypertension, but also the things that can develop during the pregnancy, like gestational hypertension, gestational diabetes. For the story, risks of having a blood clot, need for cesarean section because the baby's not tolerating labor, or we think that there's something else going on, and working much more on the connection with the patient so that they understand the role of their prior medical problems and the problems they're developing in pregnancy, and so that they understand the recommendations and getting rid of that paternalistic, well, this is what I said needs to be done. And our training is very much like, this is the next step. But
right.
The finesse is getting the patient to understand and feel like a partner in their care, in that process, because it's not just generally it's not like oh my God, you need a C-section. That those are very far and few between, but it's the steps going forward of like, this labor isn't progressing well, your cervix isn't changing despite our attempts, or when we attempt to keep your labor moving along, the baby's showing signs of not tolerating it. I'm concerned you may need a C-section, but I'm very much hopeful that we can do these interventions to help the baby tolerate labor. She can have a nice vaginal delivery, which we would all very much prefer, because you're going to recover faster, you're going to feel better, and you're not going to have major surgery. And how you finesse that part so that you're partnering with the patient along the way, so it's not a shock when you get to that point. Because sometimes I hear these family stories and I think it was a complete shock that they needed a C-section, and how am I always making sure that I'm doing that part of things, so that the medical model and the physiologic, yes, most of the time, yes, pregnancies are low risk, but I'm famous for saying low risk as a retrospective diagnosis, meaning that we can look back and say everything went completely as planned and we're 6 weeks post out and we haven't had any complications. But we still need to work to better.
So I'm going to say something that sounds kooky for an OBGYN, but I do think that the way we manage labor leads us to the outcomes we're getting. And that some of the you need a C-section is, okay, we created the need for the C-section, and now we have to tell them that they need a C-section. And that there's part of our practices, you know, our low-risk patients that would qualify for birth center birth don't have a 6% cesarean rate. You know, they probably have a 25% cesarean rate. So my belief is there are things we're doing with good intentions because of the way that we create our own data from our own system, that we're getting the outcomes that we get. And, you know, it's really shocking to OBs when they hear that people who are choosing home birth or birth center birth are choosing it because they think it's safer. That's one of those things that's incredibly shocking to obstetricians, because when something bad happens in the hospital, it's like, well, you know, bad things happen. And when something bad happens at home, it's like, well, that's because you tried to have a home birth. But I do think that some of, you know, and because we're in an inherently racist system, and most of the care providers in the hospital are going to be white, perhaps the way that we manage labor disproportionately affects women of color because their experience of it is more racist and more not listening and more discounting than the white patients.
So where does research fit in all of this, and workforce development? Those bells keep going off in my head as I listen to all of your thoughts and feedback. What do you think? Amy, Dr. Greenfield, JC, Shannon?
Sure. I gave a talk a while ago. I don't even know when it was on what it takes to become a doctor, and some of that's sort of like similar to people who like want to be a midwife too. Like there's a lot of steps to it. But I said, you know, one of the first things we have to discuss is how we educate people starting in kindergarten in this state, because this was for some stakeholders within the state. And I said, you know, unfortunately, because of racism and because of finding the like long-term like redlining and those things, like African-American kids tend to live in poor zip codes, which means that their schools are not funded as well. And they don't have the same opportunities as my kid who lives in an upper middle class neighborhood. So they start off behind there. And so how can we expect them to be part of a healthcare workforce when we don't even give them the tools to get through high school the same way kids out in the suburbs do? You know, and then, so it's a whole like it starts much earlier than like, how do we get them to choose to go into nursing when they go to college? We have to get them to where they have the strong background that they can actually think that college is what they want to do, and that midwifery or being a physician is what they want to do. And so it becomes this like, they don't see people that look like them doing that. They're not supported along the way. And I don't have that answer. I see what it needs to be, but I don't have that answer.
Yeah, there's been programs to go into middle schools and expose the kids to health professionals who look like them, or just to talk about that it's, you know, it's something attainable. I don't know whether there are data on the outcomes of those programs. They're very labor intensive and they don't usually reach whole populations. It's usually like an intervention for one school or an intervention for one class. You know, I think those things being done on a much bigger level, you know, could make a difference. When I applied to medical school, I had never met a woman doctor, and I almost didn't apply because I absolutely could not picture myself And I remember the first time I saw a fourth year medical student who I thought kind of looked like me, and I just almost cried. And like, I can only imagine, you know, what it's like for people of color who don't see, what the kinds of things that are portrayed are not positive, and it doesn't feel attainable, So I agree, Amy. I think, things need to start really early with interventions to make kids feel confident that they can do this and give them the academic tools, but also the self-confidence tools. One of the things I hear, I'm one of the assistant deans for student affairs at Case Medical School, and I hear very much more from the minority students about feeling like imposters. So how do we do that? Because it's true. I mean, patient outcomes are better. Minority patient outcomes are better when they have minority care providers. Like, that's one thing we can do, improve the workforce. But, I think it takes really going back early to improve the pipeline to really move that forward.
I would be interested to know if there's any, and I've never looked this up, if there's any data on places that have, like, maybe not every caregiver is African American, but that within that department, or that the patient is regularly exposed. Because like a lot of practices will do where the pregnant patients see everyone in the practice, so that they have met them all, so that whoever is on call, they've met them at least once during their prenatal care, so that whoever's on call is going to do the delivery if they come in labor. And I wonder, it would be almost interesting to see how a group where they met everybody and there's at least one person that looks like them, whether it's Hispanic or African American, versus being in a group where no one looks like you. And do they feel more heard? Do they feel that the care is different? I don't know, because you start to get a sense of like, okay, I belong here because there are other people within here, even if they don't all look like me. Some of them look like me, so they clearly are accepting of people who look like me, versus like everybody is white, from the medical assistant to the nurse to the doctor to that, and I'm here, but I'm not sure that anybody wants me here. I don't feel like I belong because I don't see anyone that looks like me. Does that make sense? And I don't know that there's data on that, but it would be interesting, because we're never going to get it where like every African American woman, every Hispanic woman, even every white woman, that the person who shows up is going to look exactly like them at the time of the delivery. But can we make them feel more welcome, or do they feel more welcome because there's an overall mix within their care team at all levels?
Very interesting. Thank you, Amy. So I know we're at time, but I just want to highlight what's next. We have our Black History Maker series every Tuesday in February from noon to 1, and it's on Zoom. And related to this topic, Aftershock, the documentary, we have Michelle Browder. She is an artist, activist, and visionary for the Mothers of Gynecology Monument. And Linda Bradley, she's a physician at Cleveland Clinic. And we also have our Mission Health Equity Challenge Series, challenge number 4. It's our CTSC Health Disparities Unmeeting, Sparking Conversation to Enhance Health Equity Research. So exactly what we're talking about here. Maybe that's a research topic that someone will take up, Amy. And that's Thursday, March 16th from 10 a.m. to 2 p.m. That's also on Zoom. And what can you do today? Schedule a ready consultation at spark.case.edu, and that would likely be with me. Sign up to attend future programming and review some of our DEIA, diversity, equity, inclusion, and accessibility resources on our website. And thank you so much for joining us. Have a great afternoon and week.
Thank you so much for hosting.
Thank you, Amy.
Yes, thank you. Thanks for giving us the opportunity to watch it. That was really great.
It's our pleasure.
I would like to bring it to my department. That's my next goal.
Please do. Let's connect. Happy to
Oh,
help.
that's a good idea, Marjorie. That's a great idea.
Yeah.
Excellent idea. All right. Thank you.